So welcome everyone to this session on ending cryptococcal meningitis deaths by 2030. My name is Dr. Angela Loyse. I'm an infectious diseases physician, researcher, and I also lead the CryptoMag advocacy group. It's a beautiful day here in London, and our session today is about working together on saving lives from meningitis right here. Our session today is brought to you by the 5FC HIV Crypto Consortium that is led by the Drugs for Neglected Diseases Initiative. The session is also brought to you by St. George's University of London and the CDC. Our consortium is focused on the development of a new formulation, a slow-release formulation of flucytosine, a key medicine that is life-saving for the treatment of cryptococcal meningitis. Whilst there have been a number of advances in the field, our session is happening today because the situation remains unacceptable. Tens of thousands of people living with HIV are dying unnecessarily. Many are undiagnosed, and even more do not have access to effective treatment. However, we have a number of the solutions. We have very powerful strategies, both for prevention and treatment. So prevention strategies from the REMSTART trial, treatment strategies from the ACTA trial, which clearly showed that flucytosine was a key medicine for the treatment of cryptococcal meningitis. And we're excited in this session to have the results of the AMBITION trial outlined to us. However, access remains a key issue. And Amir Shroufi, who will be co-hosting the session with me, has a wealth of knowledge in this. And in terms of the access issues, there have been notable progress. We have got programs such as the UNITAID-SHI program, the 5FC HIV access program, and also there are a number of countries, including Malawi, who have got commodities from the Global Fund. However, the gap remains very large. And if we're going to successfully translate the results of these powerful trials into strategies that reduce mortality in routine care settings, we need to focus on other elements which are not given enough attention. So local leadership, education, mentorship, and quality improvement in healthcare delivery, particularly in hospital settings that have often been neglected for many decades. And whether this is for cryptococcal meningitis or advanced HIV disease, these challenges do need to be faced for other disease areas, including AMR and also, dare I say, pandemic preparedness. So I am delighted to be hosting this session with you today with a number of colleagues. Dr. Amir Shroufi is a public health doctor who is currently working with the CDC and has a wealth of knowledge on access to cryptococcal meningitis commodities. Sharon Ann Lynch is a senior scholar from Georgetown University, and she will be chairing one of the roundtable discussions at the end of the session. And last but not least, Carol Raffel from the South African DNDi office will be closing our session. So here's the outline of our session today. We'll hear from Amir about the issues regarding access to cryptococcal meningitis medicines and tests. We'll hear also about excellent progress in Uganda from Dr. Kateribi. We'll then move on to a session on yet new advances in this field. So the AMBITION trial, the outline will be given, and Tom Schiller will be presenting an exciting new initiative called Ending Cryptococcal Meningitis Deaths by 2030. We'll then move straight into roundtable discussions, which will be chaired by Amir and Sharon Ann. And really the aim here is to make this a goal-orientated session. And in many ways, today is the beginning of a number of discussions and action points. What can we do today to end cryptococcal meningitis deaths by 2030? We do have a time at the end for a Q&A, which is 10 minutes, that will be moderated by myself and Amir. So do have your questions ready for those last 10 minutes. Time is short because we're very ambitious in this session to move forward with the agenda, and we're very happy to continue the discussion and answer your questions offline. So at this point, I'll hand over to Amir, who will be focusing on access to cryptococcal meningitis commodities. Thanks, Amir.
Thanks very much, Angela, and thanks for the organisers for the opportunity to speak as part of this session. I will keep this introduction very brief. We've heard that cryptococcal meningitis is a leading killer of people with HIV, yet the strategies and the targets to do something about that are not there. Access to medicines is very low. The systems in country that are needed to manage people properly are not strong enough. And there needs to be research and development into new, better medicines and more donor support. And as Angela said, Tom Triller is going to talk about a new global framework and initiative that hopes to address some of these gaps. I want to focus very briefly, just for a minute or so, on access to medicines, because it is something that really is within our grasp to address in the short term. There is a medicine called flucytosine, which in combination with amphotericin B for induction therapy in cryptococcal meningitis could greatly reduce mortality. This drug is available today, and yet the vast majority of people who need this life-saving drug do not access it. Even fewer people who need access to a drug we will hear much more about, liposomal amphotericin B, access that. Hardly anyone with cryptococcal meningitis gets that, although we hope that will change with the UNITAID-CHI project that's supporting delivery of that and other commodities. Even when these medicines are present in country, they often do not get to the people who need them. Changes in practice are happening too slowly. Registration of these medicines is taking years, literally. And in the panel discussion, we will hear from people who are working to address some of these challenges. We will hear from countries about what can be done. We will hear from implementing partners about what they are doing to support this agenda. And we will hopefully hear from civil society, bearing in mind that really one of the most effective drivers in change when it comes to AIDS death has been civil society pressure. And I just want to finish with a quote I heard from an activist on a podcast recently, where he talked about the importance of optimism in activism for people who want to see change, but also the importance of being impatient, because just being an optimist on its own isn't always that useful. So I think I would suggest perhaps we could take a cue from the activist community and all be impatient optimists that things are going to start to improve when it comes to the unacceptably high toll of deaths from cryptococcal meningitis. So I would like to, at this point, hand over to Dr. Cordelia Kataribi, National Coordinator for HIV Care and Treatment at the AIDS Control Program, Uganda. Cordelia, over to you.
Hello, everybody. My name is Dr. Cordelia Katurebe, and I'm pleased to be presenting at this conference. My topic is going to be talking about cryptococcal meningitis and sharing the Uganda experience. I will take us through briefly our overview of the advanced HIV disease agenda in Uganda, focusing on cryptococcal meningitis and highlighting our implementation plan for the country and how we have managed to deal with this situation. Uganda is one of the countries that is found in sub-Saharan Africa, specifically in East Africa, with a population of about 41 million people and with an estimated 1.4 million people living with HIV and with a prevalence of 6.2. Currently, about 1.2 million are on ART. And in respect to advanced HIV disease, we follow the WHO guidelines that define advanced HIV disease. In focus, we look at about a quarter of people who initiate treatment in Uganda having a CD4 of less than 200, which translates to about 25,000 people living with HIV that have advanced disease. Mortality from cryptococcal meningitis is about 21%. And we have seen a growing number of people that come after treatment failure and also contribute to the number of people that have advanced HIV disease. Based on this, the country went into a criteria for strengthening our programming for cryptococcal meningitis. And this was against the background of poor access to drugs, poor access to the lab logistics, and also access in terms of healthcare worker training and mentorship and capacity to manage this. Our scale-up services and service delivery model included establishing of commodities for the scaling up of cryptococcal meningitis to ensure that service delivery happens. This ensured that we have the right treatment that was coming in. We had support through our collaborations from the Clinton Health Access Initiative through Unit Aid that brought in the necessary commodities. We also had a plan to ensure that health workers are trained in all the facilities. And currently we could see that just a few hospitals in the country were ensuring commodities and care for people with cryptococcal meningitis. And therefore, we took up the services and ensured that we establish a delivery model for ensuring that care for cryptococcal meningitis happens. The hub and spoke approach is what we use, and this is where we have tertiary centers of care that offer symptom screening. They're able to offer the lab testing for CD4, and most important is to offer the CRAG screening, which supports the screening for cryptococcal meningitis. This happens at all levels. However, we have the hubs, which are the regional referral hospitals, some district hospitals, and the regional laboratories, which support the comprehensive inpatient and outpatient care, laboratory capacity, and diagnostics. This map shows us our treatment centers that have been established as a way of ensuring that we rationalize treatment, care, and support. And of note to focus on is that our cryptococcal meningitis program aims at strengthening management of cryptococcal meningitis at these regional referral hospitals, and the spokes being the lower tertiary, the lower facilities that are involved in the inter-referral and intra-referral of patients that need specialized care. Coordination and oversight, referral systems, ensuring an uninterrupted supply of drugs, building capacity of providers, and ensuring that we have a robust data performance with indicators and quality improvement. This is the package that we have across the levels of services in terms of our health system tiers, and we can see right from the lower facilities up to the upper facilities, defining a defined package for healthcare facilities in terms of the care that we provide. We have a toolkit that supports management for cryptococcal meningitis, including screening up to the point of providing care and referral. We have a treatment capacity building program that looks at empowering the healthcare providers in terms of materials, selecting sites and training them, and including the monitoring and evaluation. When we look at the data, we find that we are able to collect data from the tertiary institutions, and this slide just gives us a snapshot of the mortality that we see even when we have treated patients with cryptococcal meningitis, again, just to show the burden. So based on this, there are lessons that we have learned from our implementation of the program. And just to note that as a country that is resource constrained, we have rationalized our treatment, our screening, and our oversight and coordination for cryptococcal meningitis across the different tiers of the health system, right from the regional referrals and up to the lowest health facility. However, we still have challenges in limited availability of advanced treatment, inadequate record keeping, inadequate supplies, especially for reagents and laboratory monitoring, and then also the high turnover of trained staff. Needless to say that despite these challenges, we think as a country, we have defined our implementation plan. We have also defined the key strategies that we are going to use to address cryptococcal meningitis. And we think we are on the right path towards achieving. And once we address these bottlenecks and find ways of mitigating them, the country should be good to go. I want to acknowledge the Ministry of Health in Uganda and our key partners that have supported us: the Clinton Health Access Initiative, the Diflucan Donation Program, Global Fund, PEPFAR, and the Infectious Disease Institute of Uganda that has supported us to roll out and strengthen the cryptococcal meningitis program. Thank you very much.
So thank you very much to Dr. Kateribe, who shows the excellent progress in Uganda. So where access is available, there is excellent leadership, training, and strengthening of health systems, very significant reductions in mortality. So thank you, Cordelia. I'm now going to move on to the next section, which is about where are we going. So first of all, we have, as many in the audience are excited to hear, Joe Jarvis outlining the Ambition trial results that will be presented in full as a late breaker this Wednesday. Joe Jarvis is a professor of tropical medicine and international health at the London School of Hygiene and Tropical Medicine. He's based full-time in Botswana at the Botswana Harvard AIDS Institute Partnership, where he leads a program of research focusing on advanced HIV disease. So over to you, Joe.
Thank you very much for inviting me to talk about the Ambition trial today. I'm presenting on behalf of a very large consortium of investigators from 5 African and 2 European countries, and would like to acknowledge them here, along with our funders, the EDCTP, the Swedish International Development Agency, the Wellcome Trust, the UK Medical Research Council, and the UK Department of Health and Social Care. I know the session is billed new trial findings, but I'll have to keep you in suspense in terms of the main results until our oral presentation during the late breaker session on Wednesday at 10 o'clock. This audience needs little background to the clinical need behind the trial, but these are the recent data with 2-week courses of amphotericin B deoxycholate, the current standard of care for cryptococcal meningitis in many settings. And we see between a 36% to 41% acute mortality across Africa and Asia with these treatment courses. And because cryptococcal meningitis remains the commonest cause of adult meningitis across much of Southern and East Africa, and these treatment outcomes are poor, cryptococcal meningitis still accounts for about 15% of all HIV-related mortality. So why are treatment outcomes so inadequate with 2-week courses of amphotericin B deoxycholate? Well, in part, this is because amphotericin B deoxycholate is toxic and difficult to administer in resource-limited settings, where giving 2-week courses of intravenous therapy that require close toxicity and clinical monitoring can be very, very challenging. We see thrombophlebitis. About 15% of patients will develop nosocomial sepsis. Patients get infusion reactions. The drug causes severe anemia, renal impairment, potassium and magnesium wasting. So how could we get around this? Well, one option is to give shorter courses of amphotericin B deoxycholate. There are good animal model data suggesting that this should be possible. These are data from rabbit models, and short courses of just 3 doses lead to about the same rates of clearance of the fungus from the CSF as standard daily dosing over 14 days, as shown in the top 2 panels. And the bottom panel here shows that when you cull these rabbits at day 14, the fungal burden in the brain is about the same in rabbits who have received just 3 doses compared to daily dosing over 2 weeks. And abbreviated amphotericin B deoxycholate regimens have been tested in humans in the ACTA trial, which was presented at IAS almost 4 years ago now. And this showed that a 1-week course of amphotericin B deoxycholate plus flucytosine led to a 24% 10-week mortality compared to 38% mortality with 2 weeks of amphotericin B and flucytosine. What about liposomal amphotericin B? We know that this drug ambisome is less toxic. It can be given in higher doses. We know that it has excellent tissue penetration and a long tissue half-life. And we know from experience in other diseases, such as visceral leishmaniasis, that you can get effective, long-lasting therapy with just a single very high dose of the drug. Its use in cryptococcal meningitis has previously been limited by cost, but short courses and reduced pricing could make it a cost-effective option. So we needed to define the most effective and the most cost-effective schedules for its use. Like with amphotericin B deoxycholate, we had good animal model data suggesting that very short courses of high-dose liposomal amphotericin B may be effective. These are data from a murine model with plasma levels of amphotericin B shown in red and levels in the brain shown in black after a single very large 20 milligram per kilogram dose in the mice. And what you see is that after that large single dose, you get a very frequent brain levels of the drug, and it stays around for a long time with a terminal half-life in the plasma and the cerebrum of around 133 hours. Based on these data, we performed a phase 2 study with the primary endpoint of early fungicidal activity, EFA, or the rate of clearance of Cryptococcus from the CSF over time. We compared standard dose ambisome 3 milligram per kilogram per day plus fluconazole for 14 days to a single high dose of ambisome 10 milligram per kilogram on day 1, given with 14 days of fluconazole. 2 doses, ambisome 10 milligram per kilogram on day 1 and 5 milligram per kg on day 3, or 3 doses, the large dose on day 1 and 5 milligram per kg doses on day 3 and 7. And what we found was that we saw a rate of clearance of minus 0.41 CFU per mil per day with the standard dosing, minus 0.52 with the single dose, 0.47 with 2 doses, and 0.54 with 3 doses. And in our formal non-inferiority analysis, the graph on the right of your screen here, showing the point estimate for the difference in clearance of infection between control and 1 dose, 2 doses, or 3 doses of ambisome, we saw that all high-dose short-course regimens were non-inferior to control. We saw that the point estimate for clearance was in favor of the high-dose short courses in all 3 regimens. And we also saw that there was no evidence of a dose effect response here, with maximal fungicidal activity being achieved with a single dose and no additional benefit from the further 1 or 2 doses given in the longer courses. As well as being a highly fungicidal regimen, the single high dose of ambisome was also very well tolerated. We saw very few grade 3 or 4 adverse events. And just to compare this to our prior experience with amphotericin B deoxycholate, we saw a 14% increase in creatinine over 2 weeks of induction therapy using the short course ambisome regimens compared to 73% increases in our prior studies using amphotericin B deoxycholate for 2 weeks. And we saw an average drop of hemoglobin over 2 weeks of 0.9 gram per deciliter across the ambisome regimens compared to 2.3 grams per deciliter with previous experience with amphotericin B deoxycholate regimens. Based on these phase 2 data, we went on to perform a phase 3 study, the Ambition CM phase 3 trial, comparing the single dose liposomal amphotericin B 10 milligram per kilogram to the current WHO recommended 1-week course of amphotericin B deoxycholate given with flucytosine. And you'll note here that our single dose arm was liposomal amphotericin B 10 milligram per kilogram per day given with an optimized backbone of fluconazole and flucytosine based on the ACTA data showing that flucytosine was an essential component of induction therapy regimens. Our primary endpoint for the trial is all-cause mortality within the first 10 weeks with secondary endpoints of early fungicidal activity, 2-week mortality, tolerability and adverse events, and cost effectiveness. And we were powered for a 10% non-inferiority margin at 10-week mortality with 850 patients per arm. The trial was conducted across 5 African countries, Uganda, Malawi, Zimbabwe, Botswana, and South Africa, and we commenced recruitment in early 2018. Overall, 844 participants were recruited, with the last follow-up visit on June the 10th, 2021. So to summarize, we hope that a novel short course treatment using liposomal amphotericin B would transform the management of late-stage HIV and markedly improve outcomes in HIV programs in Africa. Reductions in the need for laboratory monitoring, lower toxicity rates, and reduced durations of hospital admission, coupled with preferential pricing, are likely to make this a practical and cost-effective treatment for Africa. And please come along to our session on Wednesday afternoon to see the headline results of the trial. Thank you very much.
So thanks to Joe for an excellent presentation. And as mentioned, the full results of the Ambition trial will be available and presented by David Lawrence on Wednesday. So now to the End Cryptococcal Meningitis Deaths Initiative. I'm delighted to invite Tom Chiller, Chief of Mycotic Diseases Branch of the CDC, to present this exciting initiative. Tom, how are we going to end cryptococcal meningitis deaths by 2030? Over to you.
Great, thanks, sorry. Virtual conference challenges coming off mute. It's great to be with everybody today, and great to hear of some of the progress and some of the challenges, and obviously great to hear that we will hear the full results of the Ambition trial later this week. So thanks for that. I'm going to just briefly talk about something that I think all of us are excited to try to achieve, and that is ending cryptococcal meningitis deaths in HIV by the year 2030. Clearly, when we go after ending anything, it's challenging, and I think many of the groups listed on this slide here, as well as the Cryptococcal Meningitis Advocacy Group, or CryptoMag as we call it, was formed a number of years ago to begin to address ways in which we could bring better drugs, diagnostics, support, logistics, and strategies toward this goal of ending these unnecessary deaths from cryptococcal meningitis. I think when we think about sort of the case for developing a strategy to end CM deaths, it is in the context of advanced HIV disease, where we see different elements of opportunistic infections causing death and severe disease. And we know that we can tackle these one by one or together, but coming up with strategies specifically for each disease is important. And I think that in the case of cryptococcal meningitis, we really wanted with this initiative to make the idea of a patient dying of cryptococcal meningitis in a hospital unacceptable, and that we as clinicians and we as healthcare providers and all of us who work in this area should feel that we failed our patients when they're dying of cryptococcal meningitis. And I think that really is the underlying emphasis of this initiative as we move forward. We want deaths to be unacceptable. Clearly, when you are tackling advanced HIV disease, you are tackling a larger problem than just cryptococcal meningitis. We are all aware of that, but we are seeing the End Crypto Meningitis Initiative as fitting into a bigger piece of a strategy to end these deaths. I think one of the exciting things about where we are now is that we have a lot of the basic tools we need. We have better evidence-based interventions like screen and treat, so the preventing of meningitis in patients with AHD. We have drugs that work, and we're hearing more about new regimens, as we've just heard from Joe now. But the key here is that these tools have to be accessible if they're going to be used at all to reduce and to eliminate deaths from cryptomeningitis. This is the initial strategic framework that we all put forward as a potential roadmap for getting to zero by 2030. It sort of has 5 elements, which I'll discuss very briefly. First, sort of setting some targets. As we know, we need to come up with targets and indicators that we can measure and achieve. And this just gives some thought into some screening indicators, treatment indicators, and outcome indicators that we can discuss and use as we move forward with this initiative. It's also going to be important to get some specific support for this, and the bulk of support, as it should, works on scaling up antiretroviral therapy, which we know is critically important to helping to end the HIV epidemic. But when it comes to deaths, we all know that these opportunistic infections like crypto, like TB, are causing the majority of them in this group of patients. And so we need some more targeted funding addressing the advanced HIV death issues. Barriers to access medicines has already been discussed by Amir and others. And it's, I want to point out optimism here, maybe some inpatient optimism, as Amir suggested. But for the first time, we are seeing flucytosine become available in some countries in Africa. And we need to vigorously continue this effort to move this forward and to make these drugs accessible. That's how we're going to end cryptococcal meningitis deaths. We heard from Uganda, but clearly country implementation is key, right, to the success of this. And the roadmap lays out 6 different areas in which we can work with countries to help implement the End CM initiative. And then finally, research and development and working together. We really need to work across all sectors here. Whenever we target a specific disease in an initiative like this, we all know that we are really targeting health systems and health system strengthening. And we need to work across sectors, private and public, target efforts, fill gaps, and make sure these tools become accessible. So with that, I will say thank you, and back over to you, Angela.
Thanks very much, Tom. So we're going to now segue straight into our roundtable commitment discussion forums. These are moderated by Amir and Sharon. And really, the aim of this session is to get the ball rolling in terms of the discussion, what concrete steps need to happen, what action points need to come so that we can make this vision, this initiative, a reality. So, and thank you so much to our panel members who have joined us today on a Sunday. Amir and Sharon, over to you.
Great, thanks very much, Angela, and I'm grateful for the opportunity to ask some questions of this this excellent panel. Time is very tight to all our panelists. You'll just have 2 or 3 minutes. I apologize if I have to interrupt you. To our audience, please do submit some questions in the Q&A at the end. We should hopefully have some time for Q&A. So our panel are James Conroy, Advanced HIV Disease Director with Clinton Health Access Initiative, with that work being supported by Unitaid. Dr. Zuki Paniwi, HIV, AIDS and STI Cluster Manager, National Department of Health, South Africa. Dr. Cordelia Kateribi, who we've had introduced already, Apollo TM, Vice President, Technical Strategies and Innovation, Elizabeth Glaser Pediatric AIDS Foundation, Gilles Van Kutsem, the Senior HIV Specialist for MSF and Head of MSF's HIV Technical Working Group. So if I could start with you, James. CHI, with the support of Unitaid, has been doing a lot of great work to try to bring commodities, medicines and diagnostics into the countries where they are needed. But a lot of people still do not seem to be getting access to those medicines. I wonder if you could talk about some of the challenges of going from having a medicine in country to having it available for the people who so desperately need it. James, over to you.
Thanks, Amir. Yeah, can you hear me okay?
Yeah.
Great, thanks. Yeah, so thanks again for having me on, and thanks to the organizers. I think firstly, as you mentioned, it's important to highlight the progress that as an AHD, I guess, response and community led by Ministries of Health we've made. And it's great to see Tom mention that, we have liposomal flucytosine B across a number of countries along 5FC, being accessed by patients now at ministry-led facilities in multiple countries. So we shouldn't underestimate that as an achievement, and really should have that positive starting point. Secondly, and it was great to see Dr. Cordelia share the update from Uganda earlier, there's been fantastic progress in a number of countries led by ministries of health. And I think those countries which have taken and hit the ground running and have a lot of great experiences, it's important that we take lessons learned from those countries and build that into the end crypto strategy that Tom just went through, because I think there's a lot of lessons to learn from countries like Uganda and Nigeria where progress has been so fast. But as you mentioned, certainly a huge amount of work still to do. And as you mentioned, Amir, just having product in country is just the first point. And there's a couple of areas I wanted to quickly highlight where I see across our program and some of the countries we're working in a number of challenges and next steps that need to be taken to widen access. I think the first one, it has to be improving, and this has been mentioned probably on a number of IASs today, but improving access to CD4. Without that, we don't have the gateway to advanced disease. And across the region, there's still a number of countries where coverage rates for CD4 access across new patients or returning patients is frighteningly low still. At CHAI, we certainly believe that the Visitech CD4 LFA will go some way to resolving that, but it's definitely not a silver bullet, and nor is it a direct replacement for our potentially our CD4 platforms that we have in country. So it's not it's not a swap out. For those not familiar with that test, the Visitech CD4 test is a rapid disposable instrument-free test, which is semi-quantitative and indicates if a patient's CD4 count is below or above the critical 200 for AHD. And due to the nature of that test, I think why this is so important is it has the potential to decentralize same-day CD4 results to lower levels of health facilities, where potentially we may have access issues or reagent issues, as Dr. Cordelia mentioned previously, with CD4 conventional machines. And that can really transform how the AHD package of care can be provided. Secondly, I think more needs to be done to further decentralize AHD screening alongside CD4, in particular CRAG LFA for crypto, but also things like TP-LAM, to ensure that we're finding and identifying as many patients as early as possible. Dr. Cordelia mentioned how often CM treatment in 5FC and liposomal is centralized to larger facilities like a regional referral hospital. But through decentralizing screening, we can really widen that net and ensure we can diagnose as many patients as quickly as possible and then refer them either for treatment or for preventive treatment, whatever it might be. Thirdly, I think improving health worker capacity and confidence with these new treatment products. We've seen in a couple of countries where products now been available that there's still more to do on healthcare worker capacity and confidence in using the tests. And given the vast experience we have on crypto management from a number of different studies and centers of excellence run by many people on this call, there's really no excuse for that. And so I think as a community, we can work smarter to leverage that knowledge that we have in country through a community of learning. And we've seen a couple of models, including in Nigeria, where that's worked really, really well.
Great.
And then,
thanks. Sorry to cut you off.
No problem.
If you have one very quick point, James, we're just
the final one was just greater engagement with civil society and the importance of improving treatment literacy at the community level on AHD.
Thanks, James. To our next panelist, Dr. Panini. The End Cryptococcal Meningitis initiative that we've just heard Tom from CDC outline calls for a 50% reduction in cryptococcal meningitis deaths by 2025 and a 90% reduction by 2030. Are these targets that South Africa can endorse? And can you outline how this framework and strategy aligns with your plans in South Africa to end AIDS deaths by 2030? Dr. Panini, over to you.
Thank you. Good morning, all. In South Africa, we have a national advanced HIV disease task team that was established in 2019 to support the implementation of a robust AHD package of care, including the prophylaxis, testing, and treatment of key opportunistic infections, such as cryptococcal meningitis, as per WHO recommendations. South Africa has already achieved most of all core country-level components recommended in the advocacy framework to end crypto meningitis death by 2030, as it in table Annex 8.1. So South Africa recognizes that a great deal of work is still required to ensure the country meets proposed mortality reduction targets by 2025 and 2030. as a country, South Africa is committed to achieving these targets as part of the country's efforts to end all AIDS deaths by 2030, and will continue to work with in-country experts and international partners to implement a plan to meet these ambitious targets. This is an important component of the country's overall strategy to reduce AIDS deaths. Yes, we are committed. We'll work with other people. Thank you.
Thank you very much, Dr. Panini, for that very clear and concise answer. And I think if anyone has questions for any of the panelists, please do start putting them into the Q&A. So next, if I could ask you, Dr. Cordelia, on a similar line, those targets of reducing cryptococcal meningitis deaths by 50% by 2025 and 90% by 2030, are those targets that you and your colleagues in Uganda endorse? And I know you have spoken already about what you are doing and what some of the challenges are, but perhaps if you would like to take a moment just to outline one or two of the key things that need to happen that are not happening now for you to get there. Dr. Cordelia, over to you.
Thank you very much. And again, I'm happy to be here. As already highlighted in the presentation, I think that the critical things that countries need to be looking at. One is mapping out their data to actually understand the burden of advanced HIV disease and determine the numbers that are anticipated in terms of getting cryptococcal meningitis. So having the data and therefore determining the need for what will be needed in terms of commodities, in terms of reagents that are needed, in terms of the HR and the capacity building plans, so the use of data. Secondly, it's going to be having a robust leadership at all levels. Right now, in Uganda, we're looking at the Health Center 3. The Health Center 3 is where over 60% of our patients access care and where they are found, and then building up that leadership from the centers up to the regional referrals. So the leadership from the in charges to try and understand how this happens, and then the leadership at the national level to be able to sit and quantify and lobby for what is needed in country is going to be very, very critical, and then it can then be moved to the lower facilities. And it builds in with the challenges that we have specifically around commodities and the treatment that is going to be needed for almost about 50,000 patients that we are going to have. So for me, just to directly answer you, if we could have those two things, robust data systems. So I totally agree, having targets, monitoring them and feeding these targets to the facilities and working with them. And then two, ensuring leadership from the lowest level up to the national level to ensure that we have commodities and everything that it takes to be able to have implementation of this program. Over to you.
No, thank you. Thank you very much, Dr. Cordelia. And the point is well made. So as well as the targets, we need to be able to monitor and respond to progress against those targets. And as you say, that needs work to get those systems in place. So moving on now to Dr. Thiam from EGPAF. We've heard a lot, and we will hear more during the course of this conference about the importance of liposomal amphotericin B for the treatment of cryptococcal meningitis. And unfortunately, most people who would benefit from this medicine do not get access to it. I wonder if you could outline from the perspective of EGPAF, any work you are doing currently to improve access to liposomal amphotericin B and or flucytosine, and any specific barriers to that work that you feel would be useful to highlight. Dr. Thiam, over to you.
Thank you so much, Amir, and I hope everyone can hear me. Thank you for the opportunity. One thing concerning the liposomal amphotericin B and flucytosine, As these drugs are becoming available in the country, some of the work we are supporting the Ministry of Health to do, because our approach is to support the Ministry of Health that actually owns the program for the sake of sustainability. We are supporting them to update policies and guidelines, especially developing tools that will facilitate the rollout of the medicines as they become available. And Dr. Cordelia spoke about the hub and spokes model, which we think and we are supporting the various Ministry of Health to actually establish these models that will facilitate the management of these patients who are usually sick. You know, patients with cryptococcal meningitis, they are patients who really need quite a bit of advanced care, which is not always available at the periphery there. So we are supporting several countries where we are working the Ministry of Health to establish such system. In addition, directly talking about the liposomal amphotericin B, we are excited, and I give a big shout to Malawi, for instance, where we are working with support directly with support from PEPFAR, Bill and Melinda Gates Foundation, and CDC Foundation, you know, and in close collaboration with CHI, you know, to actually have liposomal amphotericin B in the country. It's quite exciting, and to see that patients are finally receiving the medicine in the field. So in Malawi, we work with the Ministry of Health to establish to use a quality improvement approach, you know, to introduce the medicine, and of course, building local evidence that can be shared with other countries in the region, you know, and facilitate the rollout of the medicine in other countries. In addition, the data system, we are also supporting the various Ministry of Health to establish data systems to ensure that as patients have access to these new medicines, obviously the accountability system is well established to make sure that we look at the outcomes of those patients. And finally, at the global level, we'll continue to work with the various stakeholders, you know, to push for, to advocate, you know, on availability of resources. And like we have mentioned already, we cannot talk about advanced HIV disease without talking about the availability of CD4. And that is something that we avoid, that's conversation we avoid most of the time when we are around this table, but it's something we cannot avoid, you know, discussing. You need CD4 to, you know, to actually move forward with the crack screening and other tests that the patient will do. Lastly, at the country level, we're supporting the Ministry of Health to make sure that we can track some of the, you know, other ancillary investigation that the patient we need. Amir, I will stop there. I don't want to bring back the challenges that are already well known to everyone. Thanks.
Thank you very much. And over now to Gilles from MSF. Gilles, we've seen that there's a huge challenge in terms of getting affordable and sustainable supply of medicines for cryptococcal meningitis in country, whether it be flucytosine, liposomal amphotericin B. What would be your 3 top requests to industry to help ensure such access? And as a follow-on, if you could very quickly answer the underlying issue of under-prioritization of cryptococcal meningitis and strategies to address it. Would you also have any messages to WHO and UNAIDS in that regard? So Gilles, over to you on top 3 requests to industry.
Yeah, thank you, Amir. I mean, first, it's register flucytosine and liposomal amphotericin B in all high-burden cryptococcal meningitis countries as a matter of priority. Those drugs are not registered in the majority of countries where they are needed. Where possible, through WHO's collaborative registration mechanism. Not wait for registration to ensure access, but use alternative mechanisms such as waivers or clinical access programs, as is done in South Africa. Maybe even a global access program may lead to accelerated access. Then ensure that there is a stable supply of quality assured flucytosine and liposomal amphotericin B to cope with what is anticipated to be a rapidly increasing demand in the coming months after the ambition results. Engage with major funders such as Global Fund and PEPFAR to explore in the short term a centralized procurement mechanism which would allow lower pricing through volumes whilst national supply mechanisms are being set up. Engage with national ministries of health to ensure flucytosine and LAMB are included in national formularies, and then of course continue to invest in research and development for more effective all-oral treatment of cryptococcal meningitis. And then specifically to Gilead, who at the moment has a de facto monopoly on liposomal amphotericin B. They promised to reduce the price per vial of liposomal amphotericin B to the access price of $16.25 per vial for 116 low and middle income countries. However, despite this promise, this has only been applied in 48 countries, of which only 22 have the product registered and available. So, we're asking Gilead to urgently implement its access price for every country in need and to engage in constructive mechanisms to reach that. And then also for Gilead to share publicly their calculations behind this access price, their drug registration footprint, and their manufacturing and supply capacity to verify that they, as the key supplier of quality assured LAMB, are able to fulfill global demands for LAMB for all diseases. And then one message for WHO and UNAIDS is, part of the reason why we are so far behind with advanced HIV and cryptococcal meningitis is that there is no global strategy. So if WHO and UNAIDS can work on a global strategy, as Tom has outlined earlier, to end AIDS deaths, a strategy that addresses the main causes of death of people living with HIV, and that spells out clear targets for specific causes of death, such as cryptococcal meningitis and severe bacterial infections. And for WHO, of course, I hope that the findings of ambition will rapidly lead to new preferred induction treatment for CM. Thank you.
Thanks, Gilles. And I'm pleased to say that Dr. Stephen Watiti is also able to join the panel. Dr. Watiti is a civil society activist who many of you will know, as well as being the chairperson of Uganda's National Forum for People Living with HIV/AIDS. Dr. Watiti, could you talk about, just to end this panel, just give us some perspective on the role of civil society in driving towards an end of AIDS deaths, with specific focus on ending deaths from cryptococcal meningitis by 2030? And is there anything you think needs to happen more in terms of ensuring that that voice of civil society is being listened to? Dr. Watiti, over to you.
Thank you, colleagues, and sorry for coming in late. I've had a few glitches, but through that voices of people who use the services or potential users, because society must be listened to. And indeed, they are listened to even when they do speak. I've seen this happening in my own country. But I think the big problem, which I think somebody already alluded to, is the issue of rampant treatment illiteracy. People will not ask for things they do not know. For example, now with the test and treat, we are excited that every person who tests HIV positive is put on ARVs. Now, if people don't know the other parts of the menu, if I may say, the importance of CD4, which my colleague has already alluded to. They should be able to demand this. So the issue of demand creation and the demanding for point of care technologies to make sure that these tests are done. And that we also do help them, sort of support them to be able to participate in this. Because, you know, people come with good programs, but programs, like anything, they end, but people living with HIV remain there. So you can do a program like what's being done, but when it ends, that is it. But if we empower a person living with HIV or the community with the relevant information, they will always ask, have we done, do we have the CD4 count? And then also for those who have done the CD4 count, they should know that advanced HIV disease, when your CD4 is below 200, you may be looking okay, but you need to have the test, the CRAB test, and of course the TB lamp for TB also. So I think empowering the civil society will help them to be able to participate more as partners in this fight to end these deaths.
Great. So, Stephen, thank you very much indeed, and I'm sure there will be questions for the Q&A later. So, thank you to the panel. There is indeed a lot of progress that you have outlined and work that's being done by people working very hard in country and in implementing organizations, but clearly a lot more to do. So with that, Sharon Ann, over to you for the second panel.
Thank you so much, Amir. So we have limited time, so let's consider this a lightning round, if we will. So first, Dr. Catherine Godfrey with PEPFAR. Dr. Godfrey, if the AMBITION trial shows the efficacy of a single-day infusion of LAM on a backbone of fluconazole and flucytosine, will PEPFAR strongly recommend this as a new protocol, along with all the training necessary for its partners for implementation now and in COP FY 2021? And secondly, Dr. Godfrey, what are you proposing within PEPFAR in terms of specific quantifiable targets for the treatment of CM? Over to you, Dr. Godfrey.
Thank you, Sharon Ann, for that question. In terms of the AMBITION trial, we are all eagerly awaiting those results, and I really look forward to evaluating them and looking at them carefully. And yes, of course, we would not withhold. We would support life-saving treatment for people living with HIV, particularly with advanced disease. One of the challenges, though, I have to tell you, Sharon Ann, is the use of is flucytosine, and the COVID-19 has disrupted the supply chains for many of our drugs. The ARVs, I think, are actually okay, but things like flucytosine has been really challenging. Not even mentioning the challenges that James has mentioned with registration and things. So implementing flucytosine, implementing the results of the AMBITION trial, should they be positive, has a number of challenges, logistical challenges. In terms of targets, we don't have targets for advanced disease as yet. We have gradually expanded the use. We are undertaking a survey of where to deploy CD4 testing and how what an inventory of machines and capabilities across PEPFAR countries at this point. I am not convinced that the place for the Visitech CD4 test is actually at the lower level facilities. It's actually a kind of a complicated test that needs the attention, the careful attention of some laboratory personnel. But we have to really figure out where and how to deploy CD4 testing as a gateway into advanced disease management. So once we have that figured out, then targets and deliverables can be developed, but we're not there yet. Over.
Thank you, Dr. Godfrey. I wish we had more time to go deeper into the CD4 question for sure. But over to Unitaid, we have Pamela Nwagi with us. Pamela, thank you for joining. I have two questions. One is long, so bear with me. So first off, what is UNIDAID's quantifiable goal for optimal CM treatment coverage within or across the countries that you all are supporting? And how far are you towards that goal? And the second question is linked to what Gilles from MSF raised, which is access to LAM. So given that Gilead promised 3 years ago to make the drug available at a price of $16.25 per vial, and that has only been realized in less than 20% of the countries 3 years on, will UNIDAID, that originally welcomed this initiative, monitor and list the countries, the 116 countries, as well as the status? Is it available at the price? Is it registered? Pamela, thank you so much, and over to you.
All right, thank you, Sharon. On the first question, UNITAID's quantifiable goal for optimal cryptococcal meningitis treatment across the project countries. So UNITAID is implementing the Advanced HIV Disease Project in 9 countries to date through CHI, and the range of interventions is from market preparedness and negotiating prices and products like 5FC, to country implementation, which involves working hand in hand with the ministries of health to, first of all, revive or rejuvenate AHD programs, which are at different levels of, I would say, maturity in the different countries, and also developing M&E frameworks with the Ministry of Health and targets therein for attainment of goals for cryptococcal meningitis treatment and screening and diagnosis in the countries. So because the situations in the different countries are very varied, so the targets are unique for each of the countries, so it would be difficult to generalize. However, the call to end cryptococcal meningitis by 2030 presents a great opportunity for proactive engagement and involvement of the country ministries of health and AHD programs to support buy-in, alignment, and also feedback on the set targets within the call to end meningitis to ensure that this trickles down to country implementation and ensure that we all have a collaborated effort to the elimination effort, activities. And then on the second question on the visibility, the progress towards the access pricing of the 160, access to access pricing for the 116 countries. So it is, we generally do recognize that now more than ever, we do need to ramp up access, especially in the wake of increased demand for the product with the onset of mucormycosis and other indications for the product, such as the histoplasmosis. And now that we have the ambition trial results out, we're going to have more interest in adopting the product across various country programs that were not initially taking very big steps towards rejuvenating the HD programs, and we remain committed to ensuring access to the product. And we continue to work with the ARV Procurement Working Group and CHI to provide visibility on effective demand for liposomal amphotericin B in the different countries that were on the original list, and prioritize countries according to first of all, burden of disease and readiness to adopt the product, and give these insights to Gilead to ensure that they prioritize countries that are ready to actually take on the product as soon as yesterday. We continue committed to that effort, and we're working in the background to ensure that this is done. On the second, and another thing that we're doing for the medium term is working with CHI and DNDi to conduct a scoping of market sizing and potential generic supply to ensure a more sustainable and scaled up access to the product, such that we have it accessible with lower access prices and with generic alternatives that are accessible to LMIC markets. For both of these initiatives, we're working to disseminate reports. One will be a liposomal amphotericin B market report that CHI will we will work with CHAI to prepare and will be available in the next quarter of this month to show the progress to attainment of access pricing in the different countries. And another will be a report on the market sizing efforts and the scoping exercise to show us the size of the market and the potential generic manufacturers that would be willing or able to manufacture the products and increase access. This will also be available in form of a report in the next quarter. Thank you.
Thank you, Pamela. Now over to Dr. Johanna Roth. Johanna is with EDTCP. We all know that EDTCP has been instrumental in funding cryptococcal meningitis and AIDS-related research and development, as well as implementation research. So Johanna, given where we're at today, the deadly gap between what we know should be done, the guidelines, new science coming down the pike, as well as the need for always better tools and technologies. Can you talk about what are the top 3 priorities in terms of new funding, particular for these new tools and technologies, for cryptococcal meningitis, for AIDS, and how your agency can contribute towards the implementation gap? Thank you so much. Over to you, Joanna.
Thank you very much. So in general, EDCTP supports collaborative research to prevent or treat poverty-related infectious diseases in sub-Saharan Africa. And over the years, we've built a portfolio of projects on advanced HIV and cryptococcal meningitis. Some of these are now close to completing, while others have actually just started. And getting to your question, I think the first point would be on the side of R&D investments in affordable and accessible drugs, as also mentioned by others. On the side of EDCTP, there's currently, of course, the Ambition trial. We've just heard from Professor Jarvis, and obviously we're also very keen to see the results coming out of this important trial. This could really transform treatment options, although, yeah, there are clearly implementation barriers to be addressed, as also explained by the other speakers. There's also the 5FC HIV crypto project. This is led by DNDi, and this study will really focus on an improved sustained release flucytosine formulation, which is affordable and accessible to more people. This is a phase 1 and a phase 2 trial. And at the same time, within this 5FC project, there will be also work done to facilitate the scale-up of 5FC implementation according to latest WHO guidelines. So these 2 studies are in different phases, and they focus on different drugs, but both, we believe, have the potential to advance the field and complement each other, and also complement, of course, other ongoing work. But it's very clear that we're not there yet, and that R&D investments in this area are really important, also to achieve the goal to end crypto deaths by 2030. I think the second point would be really on the current lack of availability of diagnostics. This is also highlighted by the Global Initiative, and of course, amongst others, UNAIDS and CHAI and their partners are doing a lot of work in this area now, but it's also an area where a lot remains to be done. So this is another one I wanted to highlight. And the third point would be more on the implementation research side. This is also an area that EDCTP has been investing in. And for example, the DREAM project is an important implementation study. It's coordinated by Angela. And this aims to reduce mortality linked to meningitis through provision of tests and treatments, to the implementation of a diagnostic and treatment algorithm, an education program, and it has also a very strong capacity building component. And one of the key aspects of this project is that it's really integrated into routine care, and that the project is really led by African investigators. It's running in several countries. It's near completion, so this is another study which we're very much looking forward to see the final result. But it's also very clearly an area where more works need to be done in the near future. So to conclude, yeah, we believe that the work that I just mentioned, together with all, other ongoing work and initiatives, could play a role to achieve the aim of ending crypto deaths. But it's also very obvious that there's a lot to be done, and more generally that it's really crucial to to invest in R&D in these areas to achieve this aim. So thank you very much, and I'll stop there.
Thank you, Gianna. I'd like to move on now to UNAIDS and WHO. I think it's incredible that you have some of the people on this panel, some of those that are involved in this advocacy group, put so much work into an advocacy document with the sole goal of trying to get UNAIDS and WHO to provide more leadership and adopt certain targets and have a strategic framework. So one has been developed, a strategic framework, and you hear Gilles and Amir calling now for a global strategy. I just want to say, do we all agree that cryptococcal meningitis is an incredibly painful way to die? Horrible headaches, deafness, blindness, coma, cerebral herniation, as was described to me by one of the MSF doctors. Basically, the brain gets pushed down into the spinal canal due to increased intracranial pressure. So I was one of those, much like many others working on global HIV, that thought ARV scale-up would solve it all, that we would be able to bend the curves for TB, that we would be able to bend the curves for deadly infectious diseases, opportunistic infections, but you still see that this is the CM is the second leader killer of people living with HIV. So we have all been focusing on the walking well, right? Where hospitals are the black hole. Meanwhile, people continue to suffer and die needlessly. So Shannon, over to you. Let's, Shannon Hader, thank you from UNAIDS for joining us. We need UNAIDS to name, talk about, and lead the fight against what people with HIV are dying of, including UNAIDS, including CM. So this year, will UNAIDS call for a multi-fold increase in people receiving flucytosine containing CM treatment by World AIDS Day 22? And likewise, can UNAIDS support a specific target that gets us on the path of realizing the goal of less than 20% CM mortality by 2025? Over to you, Shannon. Oh, sorry, Shannon. And what's critical, and somebody needs to work it out between UNAIDS, WHO, and others, which is gathering the information and supporting countries in order to start capturing that information, to Dr. Cordelia's point. Thank you, Shannon.
Great, thanks, Sharon Ann. And thank you to all the presenters here today. Critically important. And maybe jumping in, pain, suffering, and unnecessary loss. Absolutely. How can we frame it any other way? You know, UNAIDS, we care about the fact that we're not alleviating that at the degrees we need to. You know, we care about the fact that people are dying. And I think, as you just mentioned, and Tom mentioned as well, you know, treatment is necessary but insufficient. You know, there are still people with late disease who need something more. And I think, you know, we just released the 2020 report on global AIDS last week. And what we're seeing is that reductions in deaths, that rate of reduction is slowing. And even as we're boosting the first 90 and people finding out they have HIV, folks with late disease are not being proportionally found that way. It seems like the same people are being missed over and over and over again with the services we have now. And so I think, building on, Tom, what you mentioned for the initiative, you know, and what's happening with mortality, yes, we have to be really focused on the what, but also the who and the where, so that we can continue to move forward on this. Second, I also want to sort of share how shocking it's been to me the last 2 years as we've been developing this latest global AIDS strategy and getting the new political declaration, that in many, many rooms with stakeholders, people don't want to talk about deaths. You know, we missed the targets for 2020 for mortality. We exceeded them by 50%. And we exceeded the new infection or prevention targets by 300%. And unfortunately, over the last couple of years, that's almost felt like a reversion to trying to get to the prevention versus treatment again that we're trying to close. And so many folks that have wanted to talk about, oh, treatment's fine, all we need to do is prevention. So I have to say, my personal role in a lot of these rooms has been to be like, people are still dying. And I point that out because I want everybody who's tuned into this session, the care, to realize we do all have to be huge advocates for saying, no, people are still dying. I actually think COVID helped in a bad way put deaths back on the agenda. rather than numbing people to death, somehow it has been a tangible reminder that no, these are not just other chronic diseases. These are infectious diseases that will not go away on their own. So concretely, Sharon, I'm getting to the concrete issue of how do we get to, since those commitments and measures are not in the June political declaration, and we don't want to wait 5 years for another political declaration to start making progress. What's the next concrete opportunity? That is not just a technical document, but is something that speaks to global decision makers and world leaders. And I'm guessing this might be something that Nathan jumps into next, but this is the year for the global health sector strategy led by WHO, and for starting 2022 and beyond. And this very specific area to build in these health sector and mortality overall, Cryptococcus meningitis specific goals and elements is a very concrete opportunity in time. And that's something, when that is approved by the World Health Assembly and others, gives us an ability to add these in and amplify the call with really substance behind it as we go forward. So that's sort of how I'm looking at it right now, and want everybody's energy and advocacy to do so.
Thank you, Shannon. Speaking of the political declaration, it is incredible that the words cryptococcal meningitis do not appear, and did not appear in an intervention from the UN agencies, including UNAIDS. So Nathan, over to you for WHO. I have a lot of the same questions. You know, again, the people on the panel did develop the strategic framework in the hopes that UNAIDS and WHO would take it forward, would put some muscle behind the targets, and of course endorse the targets. But specifically, if we have more time, we can get into that. But in terms of what WHO will do, should the ambition results and WHO scrutiny of those results support a move to a one-day infusion of LAM instead of today's 7 days, how and when will WHO communicate on the need for change to countries in terms of the treatment protocol? And can we expect such a communication within the next 3 months? Second question is that the implementation of WHO's guideline, both for AIDS and cryptococcal meningitis, has been slow. And as people have pointed out, there's no global strategy to address CM and other main causes of death of people living with HIV. So what will WHO do towards improving implementation? Thank you, Nathan Ford, over to you.
Thank you, Sharon Ann, and thanks for the question. And thank you also for setting the scene for this section by reminding us all of what a horrible disease cryptococcal meningitis is, and that we really need to reduce mortality as an urgent priority. Your voice increased in passion, and I hope that doesn't come at a cost of your painful voice in the future. So I hope your voice gets better soon. Your question was really about well, you had a number of questions there, but what I would like to pick up on is the importance of WHO guidelines being up to date and responding to the evidence quickly, and the importance of WHO guidelines being adopted and adapted at national level as quickly as possible. So really trying to speed up that time frame from an important new trial result like the Ambition trial getting adopted into WHO guidelines within months and not years, as has sometimes previously been the case, and then ensuring that once WHO guidelines are up to date, they're taken up at the national level as quickly as possible. So I'm sure many people on this call are keen for WHO to move quickly on the Ambition results. We can't wait to get the full results out later this week. We need to do an evidence review, put it in a systematic review, get a guideline group together in order to update the guidelines. But this can happen in months and not years, and we've already started the process. Then there's the issue of ensuring that WHO guidelines are adapted at national level, both for, well, the crypto guidelines have not yet been updated, so that's a forthcoming activity. But something I wanted to make the group aware of is that we have new consolidated HIV guidelines that are going to be released later today. And in those guidelines, we have a chapter on advanced HIV disease, which is the first time HIV guidelines have had consolidated guidelines have had a chapter on advanced disease, and that creates an opportunity for dissemination and uptake in country, and creates an opportunity for a policy conversation about ensuring that national guidelines include a focus on advanced HIV disease. So we as WHO will be working on that dissemination process and working at national level with ministries of health to look at what's new in these consolidated guidelines and what national guidelines may need adjusting to reflect the new WHO recommendations. And then the third thing would be the training and the implementation at local level, because it doesn't stop with WHO producing a guideline in Geneva and a country reflecting those recommendations at national level. The implementation needs to get down to the clinic level, and that requires training tools, SOPs, etc., etc., etc. And WHO does have a role in that activity, those steps as well at training at the local level. So there's a program to be considered there when the new crypto recommendations come out. Perhaps I'll stop there, but I'm here for the Q&A, so I'm happy to keep talking with you.
Thank you. I need to hand over, but I just want to say one thing, that this panel was meant to be the action and commitment or accountability, I can't remember, but I suggest that we have a separate session and carry this conversation over. As you've seen from Dr. Cordelia, where there's a will and support for a way, then CM can be detected, prevented, treated, cured, that there is no need to accept today's high mortality rates, that we can double and even triple the cure rates if people are helped into managed care. So with that, Shannon, Nathan, Joanna, others, we will look to you to come back around. Katie, please, in order to have another session. I don't care if it's public, I don't care if it's private, but where everybody puts something on the table before we leave the room, because otherwise we're not going to have the action, the support necessary in order to bend these horrible curves. Thank you so much. Angela, over to you.
Thanks so much, Sharon-Ann. So we're now going to go to the Q&A session. We've been allowed an extra 15 minutes because of the technical hiccups that we experienced right at the beginning. So Amir and I have been looking through your questions. Thank you so much. There are quite a few. And as Sharon-Ann has said, very much the aim of this session is for the discussion to continue and for there to be workshops, meetings. So very much the very beginning of how we're going to end crypto deaths. I'm going to start with a response that we got to Gilles from Gilead. And then we'll move on to some questions regarding CD4 tests, donors working together. So we had a response from Dr. Harold Nusser, who says, thanks, Gilles. Amphotericin B is accessible also without registration. It is actually available in 30 countries, and we are working closely with CHAI and UNITAID to grow this number shortly. I'm, however, happy to look into it. As discussed before, supply won't be an issue. We are behind the access price and look into improvements. We also have removed a pricing gridlock in one of the countries, working on the second. And just so that everyone is aware, we are planning an industry forum where these critical discussions can be continued. I'll now hand over to Amir for the second question.
Thanks, Angela. So a question came in relation to Tom's presentation to say, is it possible that donors will come together and join efforts to address the gaps identified in the strategy? Often the responses between donors are very individualized, it says here. So I would like to, is there anyone who would like to answer that question? Is it possible that donors will come together in this way? And then leading on from that, and perhaps more importantly, what would be the ask today from donors? We heard a very impassioned call for clear commitment from Sharon-Ann. What would people like to see as a clear commitment from donors on this agenda? maybe Gilles, Gilles or Sharon, would either of you like to take that, or Dr. Cordelia?
So I unmuted faster than Gilles. So just to say, we've got the pandemic, sorry, the AIDS response, right? And there's been flatlining, and of course, COVID has interrupted or disrupted implementation. So we need to catch up on the other main drivers of deaths among people living with HIV, including TB. So TB, cryptococcal meningitis, that's what kills people living with HIV. And then alongside this, you've got governments that are putting massive amounts of money into pandemic preparedness, response, and resilience. These two things need to connect somehow, because otherwise we're going to have just more donor darlings, the supranational labs, the good donor ideas gone dusty. We have all seen them. So this funding needs to support the basics of the HIV response, but also that black hole. You know, we talk about health system strengthening, and it's an incredibly large agenda, but why don't we also talk about hospital health in terms of what are the targets, what are the supplies that hospitals need to have, what is the support for healthcare workers, hospital health, so that in addition to focusing on the walking well and keeping them well, we can make sure that hospitals are not such an inevitable place to suffer and die. So hospital health has got to be part of the consideration, both for the pandemic preparedness and response, building for the future as well, and of course, larger for the global HIV agenda. Now, PEPFAR, CDC, MSF, up until recently, it's almost as if MSF is doing penance for focusing so much on ambulatory treatment, frankly. Needs to also bulk up and stop considering hospitals a black hole that isn't worthy of consideration. We can't treat hospitals like that. Otherwise, frankly, it's like the world is treating Haiti, and it's racist and it's colonial, as if they are messed up, they will always be messed up, and they won't be able to be helped. This is not the case, and more needs to be done. Thank you.
Yeah, thanks, Sharon Ann. Maybe it's such an important issue. Perhaps I could just give a second for someone representing an affected country, Dr. Cordelia or Dr. Panini. Would you, to make this agenda a reality, is there anything you would like to say with respect to the donor community?
Yes, in South Africa, we are working together with the donor community. We are being assisted by CHI, Unit 8, in the flucytosine availability for the program. We are implementing flucytosine in 60 sites here in South Africa with the help of CHI. It's brought through the Section 26 that is not on tender, but we still use it whilst we are still waiting for registration of the correct dose of flucytosine. There is a part that donors play very hard in the implementation of the management of advanced HIV disease.
Yeah. Amir, if I can just add one small thing, Global Fund is busy writing their strategy for the next years, and I think it's really important that advanced HIV disease and cryptococcal meningitis specifically is addressed in that strategy. And I would ask the same from PEPFAR, because as long as this is not mentioned into the global strategies, it's not being prioritized sufficiently.
Okay, no, thanks, Gilles. Thanks, Dr. Panini. Some very clear asks, and maybe we can think about how those can be collated and progressed after the session. Back to you, Angela.
Thanks, Amir. And just in response to Sharon Ann's, great input. So there will be a lot more about implementation strategies and hospital strengthening during a session on AHD on Wednesday, the 21st. So that's at 8 a.m. CST. So we have 3 sessions which are focusing on implementation gaps as a driver of preventable HIV-related deaths. So I hope to see you there. The next question is to James from CHI, and the question, James, is, you mentioned about Visitech, and I'm wondering how countries need to handle the infrastructure they put in place before for CD4 testing. Thank you.
Sure, thanks, Angela. So I saw the question. I think I'm interpreting it in two ways. I think firstly, there's certainly a number of challenges with existing CD4 infrastructure, right? And I think most of us are fully aware of those. We need some severe efforts to better optimize what we have in country, noting that is probably at its maximum in terms of conventional CD4 access. And that includes better use of reagents, better availability of reagents, and more importantly, availability of manufacturing and maintenance of machines. And I think in a number of the countries where we work, that actually is a bigger issue than necessarily the availability of reagents. I think secondly, just thinking about conventional CD4, important to note that guidance still, and it's a shame to think this still 2 years later, but still needs to be emphasized on the importance of CD4 at all levels, at all facility levels. We still hear that CD4 testing is no longer required due to test and treats and the movement towards viral load, and that's really something that is a shame to still be hearing after so many years of banging the CD4 drum. Just on Visitech itself and infrastructure around that test, we've been working with Omega Diagnostics, who are the supplier, to provide free access to the tests for ministries of health and a number of partners who are on this call, to try and establish for the ministries themselves and for partners where this test best fit. And I know Katie touched on this earlier. In terms of the test itself, one of its benefits, of course, is that it's instrument free and a point of care test. So there is, it removes a little bit of the infrastructure going forward, hopefully. But it isn't the easiest test to use, and I acknowledge that. And I think we have a pretty comprehensive training package that's openly available to everyone for the test. Some of the initial feedback we are getting from somewhere like Uganda, where Dr. Cordelia is that actually, whilst it's not the most straightforward, it is able to be run at lower level facilities. And actually the benefit of being able to provide a patient with the same day CD4 result and begin the next phase of treatment is so valuable to healthcare workers, and such a positive change that actually that far outweighs any of the technical challenges or extra effort that the test itself actually may need. So we are seeing some really positive feedback on that.
Thanks so much, James. Unfortunately, we've run out of time for the question and answer session. We're very happy to continue these offline, so don't hesitate to contact us and we'll collate some of the questions and circulate. So what I think we've achieved what we meant to during this session. There's been great discussion and clear ways forward, pretty much on every element, including demand and supply for cryptococcal meningitis interventions and strategies, so that we reduce deaths urgently from this painful disease as soon as possible. There's too much really for me to summarize in a few sentences, but some of the key issues that have come up, unsurprisingly: CD4 access, healthcare worker capacity, the need for leadership, data mapping burden, 5FC registration, centralized procurement mechanisms, 5FC being in national formularies, issues around liposomal amphotericin B and access, global strategies for AHD, updating guidelines, etc., etc. And last but not least, the key role of civil society that we saw with Stephen Watiti and Sharon Ann Lynch, and need for treatment literacy. In terms of next steps, I just wanted to highlight a number of plans that are in the pipeline and also key meetings that are upcoming. So the next CryptoMag meeting will be taking place on the 5th of August. So if you're interested in joining this meeting, there's an amazing community of experts, implementation, academics who freely give their time. If you'd like to join this forum, you're very welcome. And people from civil society would be very welcome, of course. As mentioned on Wednesday, the 21st, we are focusing on AHD, so cryptococcal meningitis being a key disease that needs to be addressed to reduce deaths from AHD. And in particular, we're focusing on gaps in implementation and hospital strengthening. We also have plans for an industry forum and regional country meetings. So please do get in touch on how we keep this momentum going in terms of concrete steps so we achieve our goals. I'll just hand over to Carol Raffel. Amir, I don't know if you've got any closing remarks you'd like to make.
No, please, Carol, go ahead.
Yeah, and thank you everyone to the wonderful panelists. And over to Carol Raffel to close our session. Thank you very much.
Great, thanks, Angela and Amir. DNDi believes in partnerships to drive innovations for patients, and today's session has been a wonderful representation of this, a diverse and committed group of organizations and individuals, and really our sincere thanks to all of you for your contributions, and to Angela and Amir for doing an excellent job in running the whole session. There are great challenges, but there are great opportunities. And I think to echo the key sentiment from today, it's critical to be working together with a sense of urgency to minimize cryptococcal meningitis deaths, as they are simply unacceptable. On a calling out Sharon Ann's point about hospital health, that's something I personally feel really strongly with. So being able to connect these missions, if you like, I think is also something we really need to keep in the big picture. So thank you all for watching. It's my pleasure to now close the session, and enjoy the rest of your conference.
Yeah, so I've just been requested, Carol, thank you so much for closing our session. There are just a few key things I forgot to say. So the ambition session on Wednesday at 10, our session also on the 21st of July, same day, so 8 a.m. CST and then 10 a.m. for the ambition trial results. Please have that in your diary. And from Sharon Ann, there is a meeting for treatment literacy and advocacy for cryptococcal meningitis plan. So forgive me, Carol, I forgot a number of elements. Thanks all.
Thank you.